So, Dr. Davis, thank you for joining us at HealthTalk TV.
My pleasure. Great to be here.
So, great having you. And you are presenting a very important study, BRUIN CLL-322, here at a late-breaking session on Sunday. It's important because it's focusing on patients with relapsed CLL, which especially after prior BTK inhibitor therapy. So can you just walk us through what is the key findings of the study?
Absolutely. So this study is looking at a population of patients who are relapsed, and most of the patients, 80%, had a prior covalent BTK inhibitor. So the current standard of care right now is venetoclax with rituximab as a 2-year regimen. But the main study that led to the approval of that regimen did not include these patients who are covalent BTK inhibitor exposed. So this is the first phase 3 study to look at this population with a fixed duration therapy. And the key finding is that when we combine the non-covalent BTK inhibitor Pirtobrutinib with venetoclax and rituximab as a time-limited fixed duration regimen, we see a very significant advantage of progression-free survival with the PVR regimen. It's about a 15% absolute improvement at 2 years, which is a hazard ratio of 0.54 in favor of PVR over VR.
Yeah, that's very strong. So what kind of patients do you think will likely benefit from this treatment?
One of the things that's very interesting in the study already is that we did some pre-specified subgroup analyses. And the patients who seem to benefit most from the triplet 3-drug regimen are patients who have high genetic risk CLL with TP53 aberration, patients with unmutated IGHV, and also patients who have progressed on their prior covalent BTK inhibitor. And these are the very patients right now who have the poorest outcomes, so we're really optimistic they'll do well with this PVR regimen.
Right, so do you think this could be a new standard of care for relapsed or refractory CLL in the future?
I do think so, yes.
Yeah.
I mean, this was designed as a registrational study to lead to approval of PVR as a regimen. I think the data so far, certainly in my mind, would support that. I think there doesn't seem to be much toxicity adding the Pirtobrutinib. It's a very well-tolerated drug. So if we can get a longer progression-free survival with a fixed duration regimen, I think it's a very appealing standard of care option for patients.
Yeah. This study, was your idea to start with this kind of study, and you have had lengthy, of course, discussions with Eli Lilly. So when did you start this study in the first place?
I mean, Pirtobrutinib came into the clinic, in the late 20-teens, and I was happy to be involved with the company at that time and having discussions with them about the future directions. And we had a lot of conversations about what population to study in the relapse setting, what the right comparator arm is, and it was a nice collaboration with the company and many other investigators around the US and around the world to design this study, which I think, it takes several years for these studies to accrue and read out, but I think it's still very relevant today now with the readout.
Yes, it started back in 2019, and now we are in 2026. When do you think this treatment will be introduced first in the United States? What's your thought of that?
It's always very hard to predict these timelines. I think this is an interim analysis, and to me it's convincing enough that it should lead to an approval, but it's also possible regulatory agencies would want to see longer follow-up, so I think it's hard to know.
And survival data, of course, total OS
Overall
data.
survival, which is currently immature in this study.
It is,
yeah.
And that's a positive thing, of course,
right.
but people are living longer and due to the treatment. Just to close, Dr. Davis, what are your message to European hematologists based on the BRUIN CLL-322? What should they take with them from your study?
Well, I think it's very important now that we have phase 3 data in this population of patients who have had a prior covalent BTK inhibitor. And I think it's very clear from this study that the combination of Pirtobrutinib with venetoclax and rituximab allows for a very potent fixed duration therapy that we hope will lead to a time off therapy with very meaningful remissions and the possibility of maybe future retreatment strategies where we can actually treat these patients again with venetoclax or Pirtobrutinib or combination. So it gives a lot of flexibility to have a new regimen like this.
Yeah, obviously it will take some time before the European Union gives a go-ahead of this, because it takes longer in Europe, and also is the regulatory affairs in every country.
Yes.
But in due time, it will come to Europe as well, I think.
Yes, I hope so.
Yeah. Dr. David, thank you for joining us at HealthTalk TV.
My pleasure.
Thank you.
Take care.